is Shirley Johnson, who is our going to be talking about what is this sickle cell team. And Ms. Johnson is a licensed social worker with over 20 years of experience in areas such as mental health, child welfare, individuals with disabilities, and 10 years of experience in advocacy and care for patients with sickle cell disease. Although this past decade her career is in project management, training, and program development, Ms. Johnson led the charge in developing a foundation-funded transition program at Virginia Commonwealth University for patients with sickle cell disease age 15 to 21, and this is, I think, when we first connected, which includes a validated assessment tool used to measure transition readiness. Ms. Johnson's transition program receives statewide and national exposure, leading to expertise recognition and program highlights at local, state, and national conferences. We first discovered each other when we first started working on our patient navigator program, when actually I was still at the health department, and Dr. Smith and Shirley came over to my office to convince me that we need to do something about this whole sickle cell and hydroxyurea, and I sat there, they were well prepared, and I was like, yeah. Okay, what are we gonna do? So we're gonna be talking more about that, but Shirley has certainly been a major leader in that whole endeavor, and we're just thrilled that we have her to now formally be introduced and come start sharing some of her expertise.
Thanks, Joan, for that wonderful introduction. I really appreciate it. All right, so we've covered a lot of information over the last day and a half, and now we want to really lead into how are we going to help everyone that's at this conference get to the next step, which is forming some type of sickle cell team for your organization, or to support a sickle cell team if you are a patient or community-based organization. So we're going to go over a lot of different topics. Some of them will be included in this particular talk today. And then as we're moving forward through the remainder of today, and especially tomorrow and Friday, we're really going to help give you those tools to make that happen. So I know that with the various audience that we have, this is really important for some medical team providers so that they know how to go back to their organization and be able to try to pitch the idea of getting a team. So I'm hoping that through this presentation, we're able to give you some of those tools to make that happen. So we're going to have our polling question. Remember, I told you yesterday we want to try to keep you as engaged as we can throughout these 4 days, because sometimes it's hard to just sit here and keep listening to people speak. And so we're just going to have one polling question in our topic today. Again, I'm going to remind you to respond to the polls. Please use pollev.com/VCU Health CME, or text VCU Health CME, all in caps, to the number 22333 to answer the polling question. So, if you were developing a sickle cell team, what are key components to having a successful team? A, knowledge of sickle cell disease. B, willingness to work with others on the team. C, bringing your skill set to the team, or all the above. Now, I know Dr. Smith, he was making you all wait for the answer, but I really wanted to give you the answer that most of you seem to agree on, and that it's all the above, because as we're going through this presentation, I'm hoping that you'll really understand why we feel that this particular answer of all the above is so significant. So we're going to do 3 different talking points through this presentation. We're going to focus on raising financial support, which is extremely important, and like Dr. Smith was talking about just earlier here, how we can get maybe other avenues of support, sometimes other than research grants or going to your institution. Garnering long-term administrative support, and managing staff turnover, which nowadays is even more critical than it has been before. So first, I want to talk about how this kind of came to fruition for me. So as I became employed with VCU Health back in 2009 and was working in the transition program, it became apparent to me that we needed to do something different besides just working in the academic center to help sickle cell patients. But back in 2010, about a year after I started into this program, information was very scarce as how to make that happen. I had a case management background from what I had done previously prior to moving to Virginia, and I knew that being out in the community was really something important to try to help patients and families as they were dealing with whatever situation I was working in, to be able to kind of give them that overall approach. So Dr. Smith and I actually went down and saw Joan, who worked at the health department at that time, and we began to compile an idea of how we could submit a grant to the National Institute of Health to try to make some of this happen, and I'm going to get into that in a minute. As we sought to get this grant and begin to apply it, we began to realize that there's many different things that we needed to learn to do, which over the last 12 years now, we've actually been able to accomplish. So here's the grant that I'm speaking about. So in 2010, when we sat in Joan's office at the Virginia Department of Health and brainstormed, we were trying to figure out how things were going to kind of play out. At that time, the Affordable Care Act was in, I believe it either had just gone to the Supreme Court or was sitting in the Supreme Court for someone to, determine whether or not it was actually going to move forward. And at that time, there was a really big plug for community health workers in that particular proposal. And so we thought, well, let's formulate a grant around that idea of how we can empower patients, which at that time, the only medication for sickle cell patients that was federally approved was hydroxyurea, how we could really improve that particular process for a patient to be able to know that they're taking that medication successfully. So we were able to submit a multi-site randomized controlled trial grant to the NIH. We were funded and approved right after the Supreme Court actually approved the Affordable Care Act, and we began our planning in 2012 of how to make this happen. The goal was to enhance the adherence to hydroxyurea and also to use multiple sites around the state to see how things were progressing throughout that grant. It was a 5-year grant, and the key term that we used at that time was not community health worker, but patient navigator. At that time, that seemed to be the buzzword to use for non-clinical outreach work. So our particular CHWs, till to this day, are still called patient navigators. And the navigator was the intervention, was the drug of the new concept for trying to improve sickle cell disease care. So it kind of really helped us get to where we are today in our particular program, because without this grant, we would not have had patient navigators. And as you see me going through how we kind of got to where we're at today, you're going to understand why that was really important. So here we are. We're in this grant from the National Institute of Health. We're about 3 years into this project, and my colleague Daniel Sopp and I were invited to start sitting in on these executive leadership meetings at our healthcare system to talk about how we could better improve care for patients who were utilizing the emergency room. They wanted to focus on a very patient-centered planning process to be able to improve some of these outcomes for patients, and we were invited to the table because sickle cell disease was so prominent in our emergency room. Now, when I say being at the right place at the right time, we were literally at the right place at the right time. We're sitting in this meeting, we've been going to them a couple times. Daniel and I really don't have too much to contribute. High leadership is sitting in these meetings, and we're just kind of like, okay, what are we doing here? And then all of a sudden, they talked about these 26 patients who continued to come into the emergency department and were blowing up the cost for the institution. And 5 of those patients were sickle cell patients. And I'm sitting in this room, and I have our patient navigators working on this grant. And don't tell anybody now, because this is a big secret. Nobody should know about this. But I raised my hand and I said, well, I have a solution for these 5 patients that you're talking about that, we're working with. Why don't we let our navigators work with them for a little while? Let's see if we have a more hands-on approach, whether or not we can make this actually be better for not only the institution, but better for patient care. So our 2 navigators worked with these 5 patients for 6 months. Our goals were to focus on them trying to reduce their ED returns over a 3-day period, the number of inpatient days and the number of inpatient admissions, as well as trying to kind of figure out how we can make things better for them, and also be able to make things better for the institution. These patients in 1 year were costing the institution, these 5 patients, $6 million. $6 million just for 5 patients. So obviously they jumped at the opportunity, and we plugged in what we thought at the time was a good way to try to make this happen. So 6 months in, Daniel was our data analysis person at the time. We came up with these particular criteria of how we were going to see whether or not we were saving money. And in 6 months, we saved over $300,000 on these 5 patients. We were really proud of ourselves. And we're like, okay, now what? What do we do with this information? We know that this could work, but at the time we had 2 navigators working on a grant, which was really what they were there to be doing. We had myself kind of working as this program manager / social worker / transition coordinator, and we had Dr. Smith and Dr. Lopato had just come on to our program. So we were a pretty small shop at the time. We had lost our nurse practitioner, she had moved to Florida and retired, and we were really kind of like figuring out how we were going to make this all happen. So, after a lot of planning and prompting and help from many people in our institution, we were brought to the table with leadership. And again, sitting in this big room around this big table, Dr. Smith, Daniel, and I, with some help from some other colleagues, put together this great proposal to say, we really think if you give us money, we're going to be able to make this work for you. And we used the demonstration project as our main tool of trying to put this proposal together. So, of course, when you're sitting in a leadership, C-suite, table, and they're talking to you about like everything that's important to them, there's 3 things that are important to them: data, money management, and patient quality care. So we said, well, we could give you a really good return on investment, but we need staff. And we went back to show them that after our nurse practitioner had retired, how there was this big increase in inpatient hospitalizations and emergency room visits. Our nurse practitioner was someone totally dedicated to our program and worked continuously, almost around the clock sometimes, you would say, to really take care of these patients. And she left, and everything went where. So we said we're going to focus on 30-day readmission rates. We want to focus on reducing the length of stay, which at that time for our institution was 6.7 days, and we wanted to reduce it to the CMS level of 4.2 days. Our ED visits in FY17 had doubled since she had left at FY 2014, so we of course wanted to reduce those. And our percentage of ED returns in 3 days were projected to triple from what had occurred in fiscal year 17 compared to fiscal year 14 when she left, and so we really wanted to focus on that as well. So those kind of were our goals of how we were going to make this work. So going back to the pilot a little bit, again, I said we had 2 patient navigators, which, in this presentation, we are going to say they're community health workers, because that's the word that everybody is using now, and it makes a little bit more sense for continuity. We had myself, and we had Dr. Smith as the medical director. So the pilot program had reduced readmissions by 18.4%. Length of stay was reduced by 1.2 days, and the number of clinic appointments had doubled. And we added that into that proposal. So I kind of have this slide a little bit backwards. Apologies for that. But that was something, again, that was really kind of like enlightening to the C-suite people when they're listening, saying, well, if they could do this in 6 months with 2 people who are really only doing this for a small portion of their day, we should give them the opportunity to be able to go back and do this more frequently. This is a really busy slide, and you will have this in your slide deck, but we also want to show you how, again, we were really looking at from FY14 to FY17, all the different changes that had occurred once we lost that nurse practitioner, and to be able to show them what we really wanted to do with this program. So we go in with a proposal and we ask for the moon, which everybody told us not to do. They said, don't go in there and ask for a lot. You go in there and ask for a lot, because they're probably going to come back and tell you, we're not going to give you C, D, and E. We're going to give you A, B, and C. So make sure you go in there and you have all of your eggs in one basket and let them shoot you down. Because once you ask for something, you're probably not going to be able to go ask for it again unless you do something really extraordinary, and all they could do is say no. But in this case, we asked for everything, and they almost gave us everything we wanted, and we almost probably fell on the floor. So again, we were looking for a physician manager. At that time, we did not have a dedicated title of a medical director, even though Dr. Smith had been with VCU for an extended period of time. We wanted to enhance our physician assistant or our nurse practitioner position to really focus back again on inpatient care, because that is where, when our previous nurse practitioner had left, we began to see that huge increase of patients being admitted and staying for an extended period of time. And of no fault of anybody's, they were just staying there because nobody was really focusing on what they were doing. And in addition to that, we didn't have that go-to person to kind of work with the emergency department to even say, don't admit this person, we can do something different with them. I was a really big proponent on getting a licensed clinical social worker. Being in the field, and although I'm not a licensed clinical social worker, I do know the importance of having therapy for patients, especially patients who have been traumatized. And we all know from working with patients with sickle cell disease and our patients that are sitting in this audience today, you've had to experience a great deal of many challenges, not only related to your disease, but related to the health disparities and all the other challenges that go along with your disease. We needed somebody dedicated to our program who is going to be able to work with our team and work with these patients and build that relationship. That was a huge thing that I felt was something that if we didn't have that, we almost should not move with a medical home. And of course, I wanted to continue on with our patient navigator program. Our grant was coming to an end in 2017. I had fabulous patient navigators that had worked tirelessly to really identify and build relationships with patients. And again, not having boots on the ground, not having people going out in the community, going to the emergency department, visiting patients in the hospital, going to outpatient clinic appointments. Again, what were we going to be able to accomplish without that? And of course, I felt it was important for somebody to be able to oversee that. And then again, also having someone collect the data. We got everything in our first ask, but the data analysis, which again, ended up being a little bit of a challenge, which you will see we did eventually get that position filled. But it was extraordinary when we sat in C-suite and they were like, this is great. You guys need to do this. This population really needs to be serviced more effectively than what we've been doing at this time. So, as you know, we capitalized on the pilot. And we really wanted to, be able to demonstrate. At that time, we were given funding for 2 years. The first 6 months, we knew that we had to figure out how to make this program work and then move forward actually hiring, training, and implementing the program. So we wanted to have some really attainable goals that we could focus on throughout this 2-year time period. Of course, we wanted an evidence-based management program. We wanted to improve patient self-care and also have utilization that was used appropriately in the healthcare system. And most importantly, in our opinion, was improving the patient experience. Patients did not feel like they were being listened to. They did not feel like anybody really understood them, and we felt that we needed to give them dedicated staff who can listen, help them make informed decisions, and work within a medical home to give them the care and the outreach that they needed. We also knew that in that ask that we had given, that there were certain things that we had also missed, and we really wanted to target those. One of them that came to our attention and we realized was a really achievable goal after we had looked at the bigger picture was these prior authorizations, and that patients were really being admitted and utilizing the emergency department because nobody was really dedicated to helping them get their prior authorizations for their medications approved. There was somebody who had been, we didn't even know this, somebody who had been given the task of doing prior authorizations kind of as her secondary job without being compensated. Well, she had an entire other job to do. So when she was able to get around to doing prior authorizations for our patients, she was able to do that, sometimes working into the evening, sometimes working on weekends, and we're like, wait a minute, this can't fly. We need to be able to go back to somebody and say, we need a dedicated staff person to be able to work on prior authorizations. This would help our utilization improvement. Now, this all started with a quality improvement task force that came along with our program being approved. So, I had all these great ideas of how I thought this program should go. Dr. Smith had great ideas of how this program should go. And then our QI colleagues stepped in the room and kind of blew all of that up into the air. And they made us realize we really weren't looking at the bigger picture. So if you have the opportunity to get a funding source for a sickle cell medical home, you need to get qualified people with quality improvement background into the room with you to help you make that really happen. And we use the Lean Six Sigma model to be able to identify and put time frames and time planning on how we were going to implement this program. Now remember, we were given 2 years to make this happen, and the first 6 months were part of our building program. But we go in there and we're thinking, we kind of have this under control. We kind of know a little bit about what we're talking about, until they really started putting together the definition of what our problems were and how were we going to achieve those problems. What was the most important thing first, the first 6 months? What could we obtain in the next 12 months? And what could we obtain in the last 18 months to make this program happen? Now, you don't have to use a DMAIC model. It's strictly up to you. But if you do have the opportunity of getting people in the room who have quality improvement background and can really help you see the bigger picture, one, it's going to help you move forward faster and really be able to put your program into place. If you have a program into place, it's always still good to have somebody self-checking you besides yourself. You might be thinking you're doing a fantastic job, and then somebody comes in from a QI perspective and looks at you and goes, no, I think you could have done these 5 different things a little bit differently and maybe save money better, improve patient experience, done something differently. So wherever you are at in your process, see if you could get a QI person or QI team involved to kind of help you self-check yourself. We had this team for 2 years. We met every week for 2 hours, and we had a big, huge board of sticky notes in different colors that we said, this is where we're at here, this is where we need to make improvement, these are things you didn't think about, and we had a wall probably almost as big as this background behind us, and we just went at it every week for 2 hours for 2 years. And it was actually a very enlightening experience, and I felt like we all learned a lot about how to improve the program a lot better. So I'm going to move on past that slide because it was a little bit redundant on what I just got done speaking about. But again, this is really talking about our QI team members, what I told you we went ahead and did. I'm not going to review this again, except to tell you that it was a wonderful experience, and I'm very grateful for them, because without them, I don't think we would have even gotten to the C-suite members in the first place and then been able to keep the program moving in the direction that we needed to. Okay, so this model, you will see it throughout our presentations. We really refer to this quite a bit. We see this as an encumbersome and overreaching opportunity to work with the community and other members out there in the medical community to make this program really work. It's not all about us. We're that centerpiece right there in the middle, but there's a whole community of not only medical providers, but of community resources, community outreaches, of other community hospitals and urban institutions and everyone else out there to kind of make this a real community medical home. So you will see that we have goals, we have elements identified in here, we have staff, we have processes, and we use this medical home model quite a bit in our talks to be able to say that we are in the middle, but without these people on the outliers and then those that are out in the community, we would not be able to make this happen. Now, COVID came into place, and obviously things have changed with COVID. But as you're going to find out throughout our talks, we've been able to reevaluate and still do a really good job keeping this model even in the COVID world. So I wanted to just let you know that we did have some really good successes in our program as we were moving forward with implementation. When we had submitted our request to leadership, and you will see this, I think, in the next slide, we had given them a projection of how much money we thought we could save them once we implemented this program. And we also focused on those aims that I had spoken about. And I'm not going to go through this, but I want you to be able to see in the green numbers that you're looking at, that we did not only deliver, but exceeded our expectations of all of those goals that we had established within that first year. We were really proud of the first 2 years. We were really proud of the work that we had done, and we wanted to be able to say, we got this. You gave us money, we put that money to good use, and we want to be able to continue to do that and enhance this program as time goes on. Now, this is the money slide. This is the slide that means probably more than anything else that you could think of. So, I talked to you about what our projection was when we had gone to the C-suite. We had projected to them that we would be able to save $1.5 million if you gave us this money. We were pretty close. In 2018, we saved a little under $1.4 million. Now, I want you to let that sink in just a bit. Remember, those first 6 months, we were developing the program. We didn't really have all of our staff hired. We didn't have everybody trained. We didn't really have even an idea what we were doing. We still went in with guns blazing, and we were able to almost meet the goal that we had projected to them. And we did that in 3 ways and kept focusing on 3 key instruments of what we knew was really important, and I kind of talked about this a few minutes ago. We had data. We went over that data all the time. We had developed a REDCap database where we were having all of our staff document what they were doing with their interventions in our REDCap database. We would continuously pull this data to look and see where those aims were as we were going through that year. Of course, we wanted to save the hospital money. That's really important to them. It's important for multiple reasons. We don't want to get into those, but it's still important that we were able to demonstrate we are saving you money by you giving us this money to be able to put this program in place. And we are able to improve patients' quality of life, which was our 3rd goal. So if you look at this slide, and it's really busy and it's kind of hard to kind of move everything around, it will show you how things continue to project as we were going through that time period to be able to really look at those aims and be able to demonstrate our cost savings. Then we went into year 2, and we were able to demonstrate dramatic savings, fewer hospital day admissions, few readmissions. And you know why that was the case? We had a dedicated inpatient nurse practitioner who was rounding just on sickle cell patients, consulting with the hospital teams, working with the emergency rooms to make sure that we were not having patients admitted that did not need to be, developing treatment plans, and that will be talked about down the road here a little bit. And we really had that person focusing on our patients and giving them the quality of care that they needed. Plus, we had our patient navigators who worked hand in hand with that inpatient nurse practitioner to make sure we got appointments scheduled. Patients had their prescriptions. They had rides to their appointments. We were able to put all of those things that Dr. Smith had talked about a little bit earlier about why we can't get patients to where they need to be. It's not because they don't want to come in. They don't want to get care. There's a handful or small amount of people who may be like that. The majority of our patients did not have the resources or the ability to navigate the healthcare system without the help of patient navigators. And we were able to show a higher utilization cost trend. So if you look at this, in 2 years, $2.4 million we saved the institution. Now, this was before COVID, and we do not have our current data yet for our 2020-2021, which we decided we're going to put together this year with COVID and all the challenges we're going to have with navigating data and everything. But in 2 years with this program, they didn't give us $2.4 million to manage our program, but we saved them $2.4 million with the money they gave us. And I thought that was pretty extraordinary. We have a fabulous team. I'm going to introduce you to them here. You've met some of them already. And I want to just kind of go through a little bit what each of their roles are. In that electronic manual that I was talking about earlier today, there are job descriptions in there for each one of these particular positions that we're going to speak about. You could take those and use them as you choose or not use them at all. But I know we've been asked a lot for job descriptions, so we wanted to be able to give you all of the job descriptions that we currently had at this time. So of course you've met our two extraordinary doctors, Dr. Wally Smith and Dr. Toko Lopato. You met me and you met Daniel. But you are going to be meeting here shortly some of our other members of our team. Rachel Walls is our licensed clinical social worker, and she joined our team in October of 2020, and she's going to be speaking to you today on a couple different matters. And I believe on Friday, you're going to meet our business analyst / data analyst, who I told you we did not get originally in our proposal, but after some pushing, after about a year and a half, we were able to convince leadership we really needed to have a dedicated person managing our data. So we have Ben Jarowski, and he's going to be talking to you on Friday. These are our three rock stars, our patient navigators. Two of these navigators have been with us through our grant, Stephanie Sams and Marla Brannon, and Nakia Williams has been with us since October of 2020 as well. And Nakia, we were able to hire her because we went back to leadership to say, you gave us two patient navigators. We have over 700 patients. We need another patient navigator. So we were able to get a third patient navigator at that time. We also were able to go to leadership after our first year to say, we need dedicated nursing staff. If you remember back in our original proposal, we did not ask for nursing leadership. But we wanted to put an infusion program together for pain management and Adakveo, which was coming on the market. And we knew that we needed dedicated nurses. Remember I was talking about the prior authorization issue that we had? Well, we also knew that we needed dedicated nursing staff to work hand in hand with our patients to do all the things that were important to them. Not only manage pain if we were able to get the infusion center, which you've heard Dr. Smith has been a roller coaster for us over the last year and a half, but to also be able to be that direct clinical connection to patients, either by working with our patient navigator team, working with our inpatient nurse practitioner, our physicians, our patients. So we were able to get Justin and Kate on board, and they came right really before COVID hit in January of 2020. Micah Furless, you're going to hear from her today. She is our inpatient nurse practitioner who really rocks the floors, walking around all of our units, talking to our emergency department, helping to coordinate medication refills, and really has been instrumental in helping to reduce a lot of those costs that we had that I was speaking about earlier. And we have Austin Hardy. So Austin Hardy is completely dedicated to that prior authorization piece that we were speaking about when we were talking about what we didn't ask for at the beginning, but then realized that we needed somebody. He tracks all of our PAs. He works hand in hand with our insurance companies, especially our MCOs, to try to get prior authorizations approved once they're denied. And guess what? He's taken that off of the plate of the physicians. I remember standing in the outpatient clinics, and I'm sure physicians that are on this call or nurse practitioners are probably saying, I hear you exactly what you're going to say. And you're on the phone with that insurance company for 45 minutes on hold while your clinic is backing up because you can't get a PA approved. Austin takes care of all of that. And I will tell you this. Every position that I'm speaking about here is important, and I don't want to minimize what anybody does here. But when you think about the work that all of you are doing, just think if you had that one little cutout of somebody else helping you. Try to figure out what your priorities are, and then go and figure out how you're going to get the money for them. Now, I don't have to really tell most of you what some of your roles may be, but I did want to kind of go through these kind of quickly and to let you know some of the outcomes that we've been able to see based on the roles that we have. So obviously, an advanced practice provider, better known as a nurse practitioner or physician assistant, can now practice independently. I think you remember Joan saying when she was a nurse practitioner, there was a lot of challenges that no longer seem to exist that she was experiencing back then. But in our case, we have an inpatient support person. We also have an outpatient support APP. They can do prescribing. They work on transition patients with us. This particular position requires them to be on call with our physicians, so there's an on-call 24/7 that now goes on in our practice, and our APPs are part of that. They also work hand in hand with our other team members, like I mentioned, and they write and maintain individualized treatment plans for the emergency department and for pain management. What we've been able to obtain from having this position is inpatient ED cost savings and support, outpatient continuity. Again, getting these individualized treatment plans. You have 700 people in your adult practice, and maybe 200 or 250 of those patients continuously have to come in for some ongoing care. The doctors that are dealing with these patients want the experts, the sickle cell experts, to write those pain plans and treatment plans. Our APPs take care of that. Prescription continuity, and like I mentioned, we now have a 24/7, 365-day provider availability on call that anybody can call, whether it's patients, other practitioners, the emergency department, and they also give our team a great deal of support. Our sickle cell disease nurses, obviously their roles are to triage, first-line answers for patients with clinical questions, first-line response to vascular occlusion at home, can cancel, schedule, rearrange appointments, do pain management, and they're dedicated to our practice alone, which has really been instrumental, and they could propose scripts. The outcomes for this, they've streamlined clinical request, they provided the pain management support for the infusion program, they have the continuity to build that patient trust. And again, the team feels supported by having these clinical providers in our practice. Prior authorization specialist. In this case, it's a pharmacy tech, which I highly recommend would be the person that you would want to have in this particular role. He streamlines all PA requests to a central person, to one person. It just goes to him. He does conduct pill counts if needed. He deals directly with all insurance providers and maintains annual renewals for the prior authorizations, which, every January and June are a huge thing in our state. And he's able to streamline all of those and keep those in check. The outcomes, this has reduced our ED and inpatient admissions. We don't have many times patients now going to the emergency room because they have not been able to get their prescriptions filled. Establishes positive relationship with our insurance providers, as well as being point of contact for the insurance providers when issues come up. And he has saved this institution unnecessary cost. Licensed clinical social worker. You remember when I talked about this a few minutes earlier, I truly believe in this position, and I feel it's very critical in building a sickle cell medical home. They provide necessary behavioral health treatment, diagnosis, and assessments. They help as the transition liaison when the patient goes from pediatrics to adults. And not only that, they provide therapy sometimes to our team. We had an incident last week where our clinical social worker was giving us her viewpoint from both sides. And sometimes we need a little bit of therapy ourselves. Outcomes, they're part of a team that provides behavioral health insight into patients' needs. They partner with the pediatric social worker, and they've built a great relationship with her, who you're also going to meet today, and they streamline that care for young adults. And in this case, an LCSW is also able to bill in Virginia, so they generate revenue when they see patients in a therapeutic setting. Our senior clinical research analyst was Mr. Sopp, who you met yesterday, and his role is to conduct research projects to improve patient quality of life with new interventions. We want to make sure that we're always on the front line of dealing with our patients. And so research is a clinical component of that. So if you can have somebody who's dedicated to the research piece of it, as well as someone who's dedicated to the clinical piece of it, you're going to be able to start seeing that there's new things coming on the horizons to be able to offer patients. He works with the team to identify patients who could participate and benefit from these studies. And he also assists with data on multiple levels for further care. The outcome for this has demonstrated the institution's commitment to improve patient outcomes and to help to support the clinicians in our practice. Again, our business analyst or / data analyst, their role is to be the data collector. Their also role is to be that QI person. Remember I talked about somebody who continues to call us out when we're maybe not doing things the way we need to? That's this particular person's role. And that's how we were able to really secure the funding for this role, is to not only say we needed somebody to manage our numbers and be able to keep us on track with our aims and the different outcomes we wanted to achieve, but we needed somebody to continue to provide quality improvement oversight with the program manager and the medical director to be able to make sure that the program continues to function in the capacity that it needs to. They report outcomes to team and leadership. They're the central holder of all of our data information, and they're demonstrating a value of our program. The outcomes for this is that they've been able to assist us with tracking the outcomes to refine best practice. They determine the needs for improvements and notify management when we are maybe not doing something that we need to be doing. And they work with the hospital analytic team to determine best practice. So when somebody comes to us and says, "How is your program working?" I go to our data person and say, "Tell me how our program's working or not working." And then he puts that program together and we show leadership. Now, this is kind of a controversial position. It's my position, and sometimes this position is probably overlapped with someone else's position, but in this case, I'm going to tell you why I think this should be a separate position. There's a lot of moving parts that go with running a medical home. You have the clinical team who has a lot of clinical responsibilities. You have your behavioral health team who has their responsibilities. And then you have to have really somebody who's overseeing not only those two teams, but also working with the outpatient providers, the outpatient clinical practice, maybe the pediatric practice. You might have the community-based organizations. You might have some irate or distraught patient, somebody could go to that can streamline anything, and that is me. So I oversee all aspects of the program. I assist with program development and training. Of course, I do all the hiring, along with sometimes, depending on the particular role, maybe a clinical person needs to sit in if we're hiring an APP. I help with reports to leadership, and really I'm the gatekeeper of everything. And so the outcomes of this have been establishing a program with the identifying their needs and the positions that were necessary to keep this program moving, development, the documentation, the reporting, and the liaison to other services that might need to be met, and improve overall outcomes of the program. Now, what you did not see me bring to your attention today is the community health worker job description, because we are going to talk about that in great detail, and I really felt it might be a little bit redundant here, but hold tight because that is going to be coming in a lot greater detail. But you do have a job description in your electronic manual, which you can use as a resource for somebody who wants to look for a community health worker. Now, we also had other champions, and I'm going to use that word a lot as I continue to present here. There's other champions that have really helped make this team function. It was because of relationship building. It was just because of their investment in dealing with sickle cell patients. And it really has kind of helped us get to the place that we're at today with having, after 4 years, be able to report that I feel we have a pretty solid sickle cell medical home team. This is our inpatient team. Now, some of this has been altered a little bit because of COVID, but they are still engaged in doing the things that they need to. But even prior to the medical home being approved, and Justin, who was one of our registered nurses at the time, he was an inpatient nurse on one of our dedicated sickle cell floors, was part of this inpatient team. They had already become engaged to say, what can we do to make things better for our sickle cell patients? They recognized that there was a lack of continuity and care for them when they were being admitted to multiple floors around the hospital, and that they wanted to see what they could do to be able to improve that relationship for patients and the clinical staff that was working with them. They also came up with a tiered oral therapy plan, and I am not going to speak about that because that is going to be something that I believe Micah is going to speak about later today, but it is a plan that helps to reduce the length of stay of a patient that is coming into the hospital that needs to be seen for a sickle cell crisis. They oversaw patient admissions, discharge, and transfers, and once we got our inpatient nurse practitioner, and pre-COVID, I mean, it still exists today, that relationship is still there, but they worked hand in hand with her to make sure that the patient's needs were being met. And they collaborated with the emergency department and the ambulatory providers and the medical home leadership. It was an extraordinary team. They're still together. They don't meet like they used to, but they were truly dedicated to the patients that they were serving. And I'm hoping that the patients might have felt that dedication from them at the time. Now, when we got the medical home, we realized that part of the challenges we had was our relationship with the emergency department. We didn't really have one. It's not that the emergency department physicians weren't doing their job, and it wasn't that we weren't doing our job, but we were not talking to one another. So we decided we wanted to try to find champions for sickle cell patients in the emergency department. And we were able, with the help of our quality improvement team that I told you we worked with for 2 years, to have that first meeting with the emergency department. And Dr. Smith and I walked into that meeting with one idea, and the emergency department came and told us, boy, you're really wrong. And our idea was, we wanted the emergency department to say, or we wanted the emergency department for us not to feel like we were telling them what to do. And the emergency department came in and said, we need you to tell us what to do. These are your patients, you know them, you're the experts. And so Dr. Smith provided them an extensive amount of information, and we were able to identify clinical champions who were willing to come to the table every month to meet with us to establish best practice for sickle cell patients when they came into the emergency room. Also, our inpatient nurse practitioner who we had brought on board had done some rotations in the emergency department and had already established some really great relationships. We continue to meet with them till this day. When we were in COVID world for a while, that did not happen. I mean, obviously the emergency departments had better, more important pressing things to deal with. And I shouldn't say better, but you know how things were in the emergency department. They could barely come up, for air, yet alone meet with us on a regular basis. But we do now, we're back to meeting with them, maybe about once a month, once every 6 weeks. And they helped us identify great places to put our individualized treatment plans so that when a patient comes into the emergency room, and if they have a treatment plan, they know exactly how to go find it in the system. That treatment plan identifies the clinical plan that the providers put together in order for them to say this is how you should treat this particular patient, and that relationship is available to us 24/7 as well as we are available to them 24/7. It has become an extraordinary relationship. I cannot stress this enough, that if you can find these champions out there, someone who's willing to meet with you and listen to you, and you in turn listen to them, it's a win-win for everybody, including the patients. Now, I'm sure any patient that's sitting out there probably still feels that there's issues with the emergency department, and we will continue to meet with them, and we continue to, deal with the challenges that we have. But just so you know, we have dedicated champions in that emergency department who are out there training the residents, they're training their other staff about these treatment plans and what to expect and what the information is that we're disseminating between these meetings, and it has really been an improvement in the quality of care to the patients that we are serving right now. We also have relationships with our ambulatory clinical team. We had, for a while, again, pre-COVID, post-COVID world, we had been meeting with them monthly to try to figure out any challenges that we might have with them. And then once COVID hit, that kind of stopped a little bit. And then we moved into a new clinical building. And so we decided to work with them, this is a new team, and meet with them monthly to deal with any issues that might be going on in the outpatient setting. So that meeting consists of sickle cell disease clinicians, myself, ambulatory administrative staff, and clinical staff. We also just added in our navigators rotate through on these monthly meetings so that they understand some of the concerns that might be going on in the outpatient setting, and then they can deal with those with their colleagues. We really feel that this has been an important role. One of the things that we took on when we brought on the medical team is that we felt we needed to schedule, reschedule, and deal with bumps of our patients within our team. So we handle, mostly, I'd say 90 to 95% of the scheduling for our patients directly. Anytime we might have to bump a patient for any reason, we reschedule them. We give phone call and texting reminders to patients. Our navigators do this every single day for the next clinic time that's coming up. And we kind of monitor the no-show rate, seeing if it's improved, whether there's any prior authorization issues, any kind of complaints, transition issues. We have that direct communication now with the outpatient team, and we feel that that's really important. So I'm just going to kind of touch on this a little bit. So, when we got the funding for the medical home, we had visions of how we were going to expand on this and try to make this happen. Obviously, some of those things changed when COVID hit, but we are continuing to work on some of these things as well. The infusion center has been brought up several times. It's an up and down roller coaster in our institution, but we are going to continue to work on that and hopefully have a solution where we have a more structured infusion, a pain management program for our patients. We're really fortunate that we were able to get these drugs approved right before COVID hit. So that is something that we were working on pre-COVID. The beginning of gene therapy research, what Dr. Lopato and Dr. Smith talked about yesterday. We want to continue to expand our relationship with our community-based organizations and to establish that mentoring and support program for our patients by working in conjunction with them. We also want to continue to work with our legislature. As a Commonwealth, we need to go to our legislature to ask for funding. And in the adult adult world, we have never received funding from our legislatures until just recently, and I'm going to talk about that in a second. We want to continue to work on sickle cell disease research, including the fMRI study that you heard a lot about from Dr. Smith and Daniel yesterday, showing that we could see the impact of sickle cell disease on the brain. And we, of course, want to continue to expand our behavioral health services so that we can continue to address the psychosocial needs of our patients. We want to continue to work on our ECHO program and continue to or feel grateful that we've been able to hire our LCSW. We want to continue the collaboration you heard Dr. Smith talk about with our managed care organizations. We do meet with 2 of our managed care organizations once a month. It's a great relationship that we've been able to build over the last 2.5 years prior to COVID and continuing through COVID, which helps us network some problems that they are dealing with as well as what we're dealing with. We want to continue our partnership with the School of Engineering and Pharmacy for research, which will continue to be an ongoing process. And one of the things that I didn't talk about, and I don't have a lot of time left, so I can't really enhance on it too much, is that we've actually worked with our Virginia Supportive Housing Program to help our homeless sickle cell patients. And over the last 3 years, I think now we're coming up to, we're able to secure funding for 5 apartments for our patients based on a grant that we co-wrote with the Virginia Supportive Housing Program. We do have new positions coming to the team. If anybody knows of a biopsychosocial research scientist, please let them know that we just received funding to approve that position, and it is now posted. We also are hiring a new hourly research assistant, and we did have our APP outpatient provider leave because she was going off to have a child. So we did just receive funding that we're waiting for the contract to be signed to get a new APP outpatient provider. We have 5 years of funding to secure that, which we're ecstatic about. And of course, another one of my babies that really is passionate for me is having a transition coordinator to really help build that lifespan program for us between pediatrics and adults. And you are going to actually hear from our social work intern coming up after the break who's been trying to help get that program together. I think I'm just going to kind of go over this. And we all know that there's new drug trials on the horizon, and there was just a notice of award given that we will be a sub to the Johns Hopkins PCORI Infusion Grant, which we're really excited about. So I don't have much time, and so I'm going to go through, I guess I talked a little bit longer than I thought, but I just wanted to touch base a little bit on our job descriptions, which again I said are in the electronic manual. We want to make sure that when you're drafting a job description, you know that the knowledge and qualifications that are necessary need to be in that job description. The skills are also necessary, and what you really want that person to do, especially when in relationship to a CHW program. Now, we talked a lot about what our original goal was 4 years ago and how when we got those patient navigators that we wanted to be able to identify the importance of the things that we were able to achieve. And so those were those length of stays, the 30-day readmissions, the total costs, ED visits, etc. All of that worked out great. That's how we established our patients. Getting assigned to different navigators was based on all of these criteria that you see here. Well, guess what? We're 4 years into this program now. And we've saved money, and we realize that we need to look at how these programs are being utilized at this point. We're really in the preliminary stages of this, so I'm not able to say much about it, but I did want to tell you that we recognize that, interestingly, high hospital utilizers are not the same patient population that are high community health worker utilizers. So we're going to be looking at this further by using assessments and kind of talking with our team and seeing maybe why we think that is happening. And just kind of a little sneak preview of this is we think it has to do a lot with childhood trauma. And so I believe our licensed clinical social worker is going to touch on this a little bit when she does her presentation a little bit later today. So I'm going to let her take care of that. But just keep in mind now that we are looking at things differently when we are assigning cases now to our community health workers based on this new information that has just come to the table. Now, there's a foundation for SCAPE, and I know Dr. Smith kind of used a similar chart yesterday, but I really wanted to focus on 2 of the 4 goals that we have here so you can see how it kind of works with this foundation of this particular conference that we're dealing with. So we first feel that team intervention is really important. I've spoken a lot about the team and what we really are hoping the team is able to give to all of you if you go forward in this direction. Goals by the team are something that's really integrated as part of an individual and group process within the organization and kind of helps keep us all focused. And then we have that multidisciplinary care when professionals from different disciplines work together to deliver the comprehensive care that addresses the patient's needs. Think about the inpatient hospitalist. Think about that provider that's not affiliated with your institution and how they know that they could come in and work with this team and ask questions of this team and be able to get the support that they need, and they don't feel so overwhelmed when they're dealing with a patient that they don't necessarily have a lot of insight to or maybe a lot of experience with, but you do. Best hiring practices. I will tell you, this is a really big peeve of mine, and I'm going to just say it out loud. Full-time is a must. And the reason why I say that is you really need to have people who are dedicated to the time that they need to work with patients around the schedule of the whole team. And you want to also make sure that that employee is feeling valued. And a lot of times, maybe an hourly rate might not be as good as a salary rate with benefits, and that person then can move on, especially in today's conglomerate where we have so many jobs that are out there available. If you can, try to really focus on hiring people only at a full-time level. Also, you want to make sure that you're going to hit those barriers. You're going to hit the barriers with your healthcare institution, how long it might take for them to get a position posted, what that hiring path looks like. I was talking about that biopsychosocial research scientist position. Part of it had to do with COVID, but it's been a year and a half in the making trying to get that position up there to get posted. Realize how frustrating that is for us, sitting here knowing that we wanted to get people in those roles that we felt were really going to help the program. We want to make sure that you have posting and interviews and hiring timelines that are really kind of like in line with how things are moving along in the labor market right now. There really isn't a labor shortage. This is really something that by the time you interview somebody, they could go interview somebody else, and if they hire them quickly, you're going to lose a good candidate. And you also want to make sure that you get your staff involved if possible in some interviews. They have to work with these people too. And when they lose people because they move on to something somewhere else, or they get hired, a great candidate moves on to someone else, your staff gets frustrated and they're burdened with other responsibilities. Make sure again that you're working hand in hand with your human resource office, and make sure that the attitude and the lack of knowledge of the job responsibilities or experience is something that you address. You don't necessarily have to hire someone who knows something about sickle cell disease. You have to hire somebody who is passionate of what they want to do in working with this population. So please, please, please make sure that is something, attitudes, experience, all of those things are really important. To me, attitude means more than the experience. Yes, they need to have whatever the general criteria is, but you want to make sure that they really want to work in this population, they can work with a team, and that they are willing to take on some of the responsibilities of someone else in the event that that person gets overwhelmed or is burdened by something else that day. Again, this helps your attrition rate, so you want to make sure that you address those. And I'm going to kind of go over this kind of quickly. That's my beautiful Apollo. I'm showing my pet today. And we're going to have time for a few questions. I think we do, though. Okay.